Okay, so first I am going to start with not this one. Five minutes of meditation that we are going to use to refocus, reset, and remember why we're here. So this is a 5-minute video we're going to do together. So I'd like you to be comfortable and breathe and do as this person is going to instruct you to do. Here we go. Okay. I want us all to take a moment and remember why we're here. Refocus on your purpose for being here. Sometimes we can get distracted, get anxious, let our emotions cloud our mind. We need to come back to what is your why? What is your purpose? And hold on to that while you're still in the thick of the nursing program. But you are all smart, capable, and amazing. I don't want you to lose sight of all of this due to anxiety, frustrations, and emotions. Sometimes we just need to take a moment, reflect on why we're here, and our goal, which is to finish the nursing program and become nurses. Okay? There's some great daily affirmations that kind of put you in a positive mood, positive mindset. If you're feeling stressed, you're feeling worried, great videos out there. I like the scenery ones, very calm and relaxing. My husband likes the meditation ones. Sometimes it is hard to sit still. So I understand that this can also be frustration. But taking that moment, being aware of yourself, aware of your thoughts, and being mindful, being aware, and doing the best that you can, and doing what you need to accomplish your goal. Okay? So, to start this week, this is the beginning of Module 4. This will be your last module for this course. So week 11 is going to cover endocrine problems. You have your outcomes here, as always. You have your focus items. Currently, there is the main item I want you to focus on and use is the PowerPoint that we will be reviewing today during this session. There are additional resources here. The Perry Resource Textbook version of their copyright PowerPoint. The textbook's key points. There's also a link here to a playlist on Armando explaining endocrinology. If you need an A&P review of endocrine glands and hormones and their functions, we'll kind of touch on those a little bit. But if you need more in-depth detail A&P review, there is a playlist here that he goes through each gland and each hormone. There's a self-application. There's an endocrine game here. So if you want to play it on your own or with a group during your study group or what have you, when you open it, you have to enable Adobe Flash. And it will proceed to a game show. You enter your name, how many contestants you want. We'll add over here to your total number. and it will be just like a game show. You have pituitary, thyroid, and adrenal cortex questions. You have your players here. You can go through and just make sure that you have a review of terminology, use of those glands, hormones, things like that, or you can actually play and compete with each other. But this is an activity that you can do on your own. It's more of a terminology review. Then I have gone and found where, how best, and what other resources you have available. You have in Evolve, you have your case studies and NCLEX questions. When you go through your Evolve Elsevier account, for the resources for the maternal newborn peri textbook, you have for this chapter, for chapter 42, there are case studies and NCLEX questions located there. Also in Saunders, when you go to Saunders test exam, these are areas that I went through and searched, and there are ample amount of questions that you can practice here. As well as an ATI, under your apply and your testing tabs, you have these that you can use to apply your knowledge from this week's lecture. These are supplemental. These are additional resources, but they may help you in your own learning through the week to remind yourself how do you mix those insulins. It's been a while since we've talked about that. We'll talk about it a little bit briefly today, but just to ensure that you have a adequate memory or need to fresh up on it, there is that video case study that you could do as well. And then diabetes management, and then you have a test for the endocrine system that is for medical surgical, but most of the questions are pertaining to disease processes that we will be discussing today. I believe there's like 2 or 3 questions that are on different things that we aren't discussing, so you can flag those questions and skip them, or you can take your gander. Okay, these are the topics that we're going to discuss during this PowerPoint in just a moment. So the disorders of growth hormone dysfunction, sex hormone dysfunction, antidiuretic hormone dysfunction, disorders of iodine, thyroid, parathyroid, cortisol, and insulin dysfunction. Here are your resource chapters. So this is where all of your information has come from. And then here we are now at 10:30 for your live collaboration. We're going to start with the PowerPoint and then go into a Q&A session. At the completion of today's collaboration, your Module 4 learning assignment, you will need to provide a Venn diagram that compares and contrasts each of the following. So as I started to discuss yesterday in yesterday's session, a lot of these you can chalk up to a concept, and therefore what is the similarity, the concept versus the differences. So using a Venn diagram would be a great tool in order to differentiate these things. So I have a Venn diagram here in the files. So you will put one disorder on one side, one disorder on the other side. And so you have your differences and then your same in here. Those different disorders, they need to be handwritten and include substantial detail of the cause, symptoms, diagnostic tests, nursing, treatments, interventions, and complications of each dysfunction. So of the hypo and the hyper. And with the appropriate placement for the similarities or differences on the Venn diagram. So you should have a total of 6 Venn diagrams. You can complete these after the lecture today. So I am going to go to the PowerPoint. so endocrine disorders. Our objectives are going to compare and contrast diagnostic tests, and there's an extra text there. Compare and contrast manifestations and the interventions and treatments of the endocrine system. I'm going to get rid of this extra random text. There we go. So, hypopituitarism. So, hypopituitary is growth hormone. So, growth hormone deficiency is therefore going to be, what would it look like if you are insufficient of growth hormone? Yep, short. What else? So would they really be small for gestational age at the time of birth, or would this develop and be seen over time? Over time, right. So what would be an indicator? How would we notice this? At your well check. So when we're doing those growth and height measurements and we're comparing to the expected, the 100 percentile, if they are consistently and not consistently, but beginning to not grow how they're supposed to, having a short stature, and therefore a short stature will come with the increase in adipose type look and appearance, but compared to a child that is taller or expected height, they would have normal adipose tissue. Can't get my notes up. So there's another picture there. So then where is the pituitary and what does it do? Bring to front. So the pituitary is this little pea-sized gland that hangs off of the hypothalamus. Okay, so then it's connected to the hypothalamus, then it's connected to the medulla. I'm not sure what your comment means, Mike. Can you expand on that? The due date? Yes. So on your calendar, all of your assignments are due on and represented on your calendar that you can find here and your monthly calendar. And you also have a placeholder in the module 4 as the learning assignment is currently hitting. You have this though. So there's still a warning there that has been open since the module has been open. So what does the pituitary gland do though? There are other hormones that the pituitary secretes and is in conjunction with the hypothalamus, right? So Yeah, there's an anterior and a posterior pituitary. So though the anterior pituitary and the posterior pituitary are going to secrete different hormones, so they're going to stimulate a different chain of events. So you need to understand the purpose of the pituitary, not only as the growth hormone, but you could also have other symptoms and issues besides growth. But the main thing that you will find on assessment is going to be your growth hormone issues. So then if we are having a low level of growth hormone, how are we going to treat it? With growth hormone, right? So the best thing that we have synthetically is going to be somatotropin. So this drug I thought it would pull it up on the right-hand side. So it treats growth failure, growth hormone deficiencies. That's what we're talking about right here. And main thing is side effects. So if we're going to now all of a sudden overstimulate essentially this child with growth hormone, you're going to have systemic side effects. So they're going to have a lot of these issues, increase in thirst, urination, numbness, tingling, abdominal pain. You need to be aware of as those potential problems. But it's not going to feel well. Just like with a surge of hormones, in most of these instances, a surge of hormones is going to feel helpful. You think of menopause, and they're all of a sudden on estrogen. That surge of hormones, you're going to feel awful. Headache, nausea, vomiting, fatigue, muscle pain, weakness. So that's going to be a common thing again throughout that we'll see. So somatotropin is the main one used for treatment of hypopituitarism. So then hyper, what do we think hyper is? Overgrowth. So they have excess growth hormone. So they're growing too fast. They're going to be quite large. This may not be really diagnosed until later, so adolescents or older, because at first it may just be, oh, they're just really tall. Oh, they're just sprouting up. Growth spurts, frequent growth spurts, but this can actually be quite harmful to their entire body. So they're going to have potential problems with sexual dysfunction, peripheral neuropathy, abnormal glucose tolerance. They're going to have major issues with glucose issues. So then all of their features are also going to be enlarged. So you think about the heart is going to be enlarged, their liver is going to be enlarged, their nose, their teeth, their forehead, all of these things are grown the excess. And then what kind of problems come with cardiomegaly when your heart is too big? Hypertrophy, things like that. You're going to have all of these other problems. But the main issue that's going on is the overgrowth, right? That's what we're seeing. So what would cardiomegaly show symptoms in a client? Hypertension, good. What about with visual field defects? What would that mean? Why would they have a visual field defect? Explain that. Well, if we're talking about other organs being enlarged, your eyes could be enlarged. Compression to your optical innervations and your arteries that lead to your eye, and therefore affecting your field of vision, right? Increased cranial pressure, I'm not sure if that would occur. I don't remember that. Being a thing. No, glaucoma is slightly different. And then also, just like Ms. Love just mentioned, the altered glucose levels are going to impact your vision and retina, your kidneys, cardiac. There's a lot of conditions going on just by thinking of an overgrowth. So everything is summarized to an overgrowth. I'm trying to. So precocious puberty, what does that mean? Oh, so great question. So let's go back to hyperpituitary. So hyperpituitarism is the excess of the growth hormone. So how do we get rid of that growth hormone? I'm not aware of a medication that would do it, but yeah, you would have to do some sort of surgery, manipulation of the pituitary gland in order to decrease the output of the growth hormone. Right. Treating the cause. That's right. Okay, so precocious puberty. So this is when a young child begins to menstruate, develop breasts before they turn 8 for girls, or grow rapidly and see their voice deepen before 9 for the boys. So this does not necessarily mean now they're fertile for the female, but why do you think this has happened? No, Audrey, this is a different hormone. Increase in sex hormones. So what are our sex or androgynous hormones? Estrogen, testosterone, right. So it has, just like with a pregnant female, the increase in surge in estrogen changes the mucosa of the vaginal canal, where they get that mucus change that we talked about, right? So just with testosterone and estrogen in a young person, it is stimulating this process, but does not mean that they've hit puberty. It's precocious puberty. So it's not early puberty. It's not puberty, but it mimics and looks like puberty. That's the difference. So it mimics puberty, but does not mean that they are fertile. And yeah, it's strange. I wish I could. Sorry, this is not cooperating with me. I'm just going to do it this way because it's not cooperating with me. Right, Jennifer. So the female, even though they have a surge in estrogen and they are menstruating, as in they are having a period, that typically occurs in a normal cycle after ovulation when the ovum is not fertilized, right? Whereas the surge in estrogen in this 8-year-old female is causing the lining to shed, as in the process of puberty and menstruation, but it's not as a result of the ovum. So what causes the shedding of the lining is due to the surge of estrogen that occurs due to the ovum, right? But it's mimicking the surge of estrogen that would be when an ovum is released, but there's no ovum in this case. They're not really menstruating, but they have the symptoms and appearance of puberty, menstruation, things like that. I am not aware of any long-term effects that this can cause unless not treated. So increased excess of estrogen and testosterone, of course, have its own side effects, but the precocious puberty, having fake puberty early, itself, I do not believe has a detrimental or can issue for the future. So next is diabetes insipidus. So which hormone is diabetes insipidus? ADH, so antidiuretic hormone. So what does antidiuretic hormone typically do? What is the purpose of it in our human body? Right, no pee. So antidiuretic, so not diuresing, so therefore not peeing. So it's to control your urine output. You're going to retain that water. That's the purpose of it. So in the condition of diabetes insipidus, it's not that they have a low level of antidiuretic hormone. It's just that the body is not responding to the ADH appropriately. So what that's going to happen is that they're not going to make a lot of urine. It's not reaching the kidneys, and therefore the kidneys are not reuptaking the water, which is what the ADH would do, and therefore it excretes it all. So then what are you going to have if they're constantly peeing, 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 peeing? Dehydration, right. So they're going to have an increased fluid output, and which may lead to dehydration. So, of course, we're going to make sure that we're looking at their urine output at this time. So this would be their baseline so that we can compare it to a treatment. So they're going to have strict I's and O's, right? So we're going to need to replace fluids for these clients because they are dehydrated. They're getting it in, but then they're immediately peeing it out. So they are dehydrated. We do need to replace this fluid, may involve, electrolyte imbalances along with the dehydration as a result. That is correct, guys. So we're going to need to treat by replacing their fluids, and then antidiuretic hormone, our synthetic version in the medicine world, pharmacology world, is desmopressin. Has the same effect as antidiuretic hormone, but acts a little bit differently. So that just because the problem is that not that it's low, they're just not responding to it, right? So this acts directly on the kidneys, which is where it's not being processed correctly. So desmopressin or vasopressin are very similar. And so these medications are going to want to, are going to cause a decrease in urine output. That is the purpose, that is the expected outcome of desmopressin and vasopressin, is to decrease their urine output, but not to oliguric levels, back to the normal expected level, but compared to their baseline at this point before treatment, it should be decreased, right? So then if they're dehydrated, just like Ms. Love is saying, you need to incorporate diet recommendations, diet education. So a low salt diet, water, low salt water, and high potassium.
Ms. Taylor, that was in response to the electrolyte imbalances. So
yeah, but I was like, wait.
Yeah, I realized that you were thinking I was talking about
SIADH, and I'm like, wait, this is backwards.
No. So they're going to have excess urine water output, but ADH under normal circumstances causes potassium excretion and sodium in water retention. So they're getting rid of their sodium in their water, but you want to monitor their potassium as well. So when she said electrolytes, that's what I was just responding to.
Responding to that part. Okay, thank you. So to clarify, treatment for this will be fluid replacement and the use of desmopressin and vasopressin, which will be to the purpose of decreasing their urine output, which will be measured, which will be how we measure their dehydration levels, their urine output, and their specific gravity of that urine. So this increased water excretion in the urine, their specific gravity is going to be close to water, right? So the specific gravity will be a great indicator for measuring effectiveness of this medication as well. Yeah, disregard the previous diet comment. I was reading her thing and I misunderstood, and that's why I hesitated. Now, this SIADH, syndrome of inappropriate antidiuretic hormone secretion, is where we're going to look at diet changes. So let me see if I can make this bigger. So if we have an increase in antidiuretic hormone, what is it going to look like? Fluid excess, fluid retention, so actually we'll have a low urinary output, so antidiuretic. So this is an increased ADH hormone dysfunction condition. And so you will actually be retaining all of that fluid and not urinating it out. So they'll have the low urinary output, high levels of antidiuretic hormone, hyponatremia will be in this condition, and they will be overhydrated. So water intoxication and toxicity. I'm trying to mix those two words. So water toxicity will be similar symptoms that you'll start thinking about with SIADH. You're going to be retaining all of that fluid, and as a result, that may seep into extracellular vessels, cells, and therefore you get third spacing. So here is another comparison in this blue chart. So you have SIADH, you have dehydration, and then you have diabetes insipidus. So then you have your levels of sodium, serum osmolality, and urine osmolality. So how these are different from each other. So think back to your hormone. What does the hormone mean? What does the hormone do? Is this an excess or a decrease, deficiency? And follow it through. Oh. So question was posed in the chat of why these people would be thirsty for SIADH, and suggested that the fluid is in the interstitial spaces instead of the vessels, and that is correct. So because it is being pressed into the third spacing areas, interstitial spaces, you get that edema, and so that fluid is not where the body can use. And so the body feels that it is dehydrated, even though it is not. And, but you get the osmolality here is low. But it is related to their being overhydrated. So next is goiter. So what hormone is associated with goiter? It's similar to the thyroid, yes. It's more specifically due to iodine. So an iodine deficiency increases the thyroid gland. The increase in the thyroid gland becomes this hypertrophic butterfly vessel, which is right at the neck. So then what kind of concerns would we have for someone with a large goiter? Airway. So airway, breathing, circulation is going to be key here. So any complications that may arise with a goiter are going to be related to respiratory and airway because of obstruction, right? So then how would we intervene and get rid of that obstruction to treat this problem? Surgery, that's right. Radioactive iodine. So we can do iodine treatment to cause the thyroid to reuptake the iodine. So the problem is that it is being held there. and therefore increasing the size of the thyroid. But if we can get the thyroid to reuptake the iodine and use it effectively with medications, that is a possibility. So then moving on to hypothyroidism, what hormone is this? Right. So reuptaking all of this iodine, reuptaking the iodine decreases the size of the goiter, the thyroid gland, and therefore, once it has shrunken, you can remove it. If it's not a temporary solution. So then hypothyroidism, some of you are already answering. The hormone involved is thyroid hormone, hypothyroidism. So TSH, what are your other ones? T3 and T4, right. So then what do those thyroid hormones do for our body? A lot. Right. So the thyroid hormone regulates basically something relating to every system of your body. It balances your metabolism. It affects your heart rate. It affects your appetite, your skin. It affects a lot of things. So then if you don't have enough of that hormone, what are you going to look like and what are you going to feel like? You're going to feel like poo, right? So you're going to have, so I think of thyroid hormone as what stimulates every system, right? So then if I don't have the stimulating hormone that every system of my body needs, what does an understimulated heart look like? What symptoms are we going to see? Bradycardia, hypotension. What does an understimulated GI system look like? Constipation. What does an understimulated metabolism look like? Overweight, poor appetite, and then your sexual organs, infertility, things like that. So it's an understimulation of practically every part of your body. So then how are we going to try to Eeyore? They just, little Eeyore, don't want to do nothing, very depressed, very slow. So then here's some irregularity and brain fog. Exactly. Great descriptions. So living with hypothyroidism. So how are we going to educate or treat them? Synthroid. So levothyroxine, synthroid. So we're going to replace that hormone, right? So the synthetic version of thyroid hormone is the synthroid, levothyroxine. So we're going to recommend exercise, just with any kind of other mindfulness and depression. Being lazy, sitting on the couch, not doing anything, you're just going to feed that behavior. The only way to stop being achy is to move and be flexible, right? So their body is slowing down. Their body is very stiff. Their body doesn't want to do anything, doesn't have the energy. You need to give your body then the energy. So you need to exercise, you need to eat right, support groups for mental health, and anything that you can to keep a balance and try to help bring back that stimulation and joy back into the life. So here's a special term, Creightonism. So this is when hypothyroidism is present in infants. It can be transient in their early stages of life and development, but so then it is called Creightonism. If it is retained and it is the thyroid hormone never picks up in production or is not being able to be synthesized right or whatever, created, processed, I'm not sure the term there, then it will be then later diagnosed as hypothyroidism. So in the case of infants, they do have a special term, Creightonism, okay? So then this is a decreased level of your thyroid hormones, TSH, T3, T4s. So then what is an increase of these hormones? What is that called? Hyperthyroidism. So an increase in T3, T4, your thyroid hormones are going to be hyperthyroidism. So then what does an overexcited body systems look like? So before we had constipation. So then what is the opposite going to look like here? In a stimulated gut. Diarrhea. What's a stimulated skin temperature? Hot, warm, fever, moist, an overstimulated heart. Right, tachycardia, hypertension. What is an overstimulated muscles going to look like? Spasms, increased in contraction. So then you have cramps, weakness, because they're being overstimulated, right? Yeah. So then how are we going to treat excess thyroid hormones? How do we get rid of it? Iodine. Yep. That reuptakes the thyroid hormone, reabsorbs it. Methimazole, yes. So thyroidectomy, right? What is this abbreviation here? PTU. What medicine is that? Hello. Propylthiouracil, PTU. Right. So then that's why. Thank you, Jennifer. So that's what I was going to bring to the attention. So why do I only have PTU here and not methimazole, iodine, things like that? So PTU is going to be the safest option for a pregnant lady, right? Oh yeah, PKU. That's great Way to remember that. Good job. So then, what are some complications related to PTU? Any takers? I don't like this page. Midline. There you go, Natasha. Risk for infection. So what is that terminology? That's what I was just going to bring up these. So sore throat, fever, chills, cough, signs of infection, rash, hives, blisters, bumps. What's the condition that leads to that? Agranulocytosis. Great job. So what does that mean? Why are they at increased risk for infection? Low white blood cells, right? So if you don't have your defense, your white blood cells, to attack minute invasions of dust that comes and irritates your nose and your throat, you can't react to that effectively, and therefore you have an overreaction to it. You can't fight it, and therefore any infection may actually get worse during that time, right? Same type of thought process. So PTU is going to be one of the safer options. It's not safe during pregnancy, but it is one of the safer of the available options. Of course, with any of these conditions, you have a hormone dysfunction, pregnancy, you have wild hormones going on. You're going to have to be cared for very closely by your physician and your OBGYN during a pregnancy. So they would make the determination if this is something that you would risk versus benefit kind of situation, right? So then furthermore, with your PTU, so then staying away from sick people, great. That's a great one would. So if this woman is breastfeeding and is taking PTU, after she has labor, she has an episiotomy or a C-section, she's breastfeeding, or maybe she's wearing a breast binder and she might get mastitis. So you need to be on extra alert, monitoring very closely for signs and symptoms of infection when this client is on PTU, right? So moving on to parathyroid. So what does the parathyroid hormone do? It controls calcium. Yes, so calcium being reuptake, used appropriately or broken down. So both directions, parathyroid hormone. So if you don't have enough parathyroid hormone in the condition of hypoparathyroidism, what does that look like for calcium levels? Right. So we're going to have a low calcium. So that's going to lead to our weak, brittle bones, osteoporosis. Right. Great. So then if we have weak, brittle bones, what are we going to be at risk for? And nursing interventions need to be focused on for this client in the hospital. Fractures. So then falls. There we go. So fall alert. So mama just had a baby, had an epidural, getting up for the first time. She has a history of hypoparathyroidism, getting up very, very slowly, walking with them, being very mindful, being very aware, being extra cautious for these certain little things, right? We're already on alert for falls, right? In that situation. But for this client, we're going to be extra on alert. So then hypocalcemia symptoms. So then again, for every system, what does low calcium look like for joints and extremities? A breakdown. So like carpal tunnel syndrome. Calcium is used for muscles, right, to contract. So if you don't have enough calcium to contract, you'll actually have delayed reflexes, slow reflexes, right? So then what's the big thing with our complication associated with hypocalcemia? What's going to be your first cardinal signs that you need to be on alert for critically low calcium levels? Numbness and tingling. So what is the term there? Yep, soft sticks sign is going to be something that you can do on your assessment, right? Paresthesia, yes. So paresthesia is the term for the numbness and tingling. If the condition could progress to myxedema coma, right? So then what does myxedema coma look like? Coma. It can lead to death, yes, but what does it look like before then? Hopefully we intervene prior to that point. Everything slows. So yeah, decreased level of consciousness. They have decreased respiratory effort, shortness of breath, slurred speech. Right. Cold, that's a good one. So the exaggeration on this exaggeration is the myxedema coma, right? Oh, sorry. Myxedema coma versus myxedema. I'm getting things mixed up. But we can take the same thing. So myxedema, not the coma. So it's the skin condition. So that's the the edematous skin inflammation of fluids and oils in that interstitial spaces in the skin. So they get that weird skin shiny look. Whereas for myxedema coma, for hyperthyroidism, that's when the fluid excess becomes respiratory issues. Because the myxedema is, again, where the thyroid is, causing the respiratory distress. But the myxedema is the fluid and not pus, but it just looks gross to me. So yeah. But it's the skin, the inflammation, edematous skin area. So then with a hypo is low calcium. Did I say hyper? Oh, I did click on hyper, and therefore I probably said hyper. So hypo, yeah, is the slowing. And that's when you get your myxedema coma. I believe that's what this said too. Yeah, hypo. I'm sorry, Scott. I clicked on the slide just to go up and I clicked on the wrong one. Therefore, I said the wrong one. So then hypoparathyroid is a low calcium level, right? So then what does a hypercalcium level look like? What's hyperparathyroidism? Yep, high calcium. So what does that mean? Renal calculi, so kidney stones, yes. Muscle weakness, right? Yep, so increased deep tendon reflexes, that's great wood. So then before, when we had low calcium, we didn't have enough calcium for the muscles to utilize to contract, right? So now we have an excess of calcium in our serum osmolality due to the reuptake and breaking down of our bones. So we're taking it from our bones and keeping it in our serum, in our blood, from our sources, from our bone. And so that decreases the integrity of the bones, which then again, we're going to have our concern for fractures, for falls, same sort of interventions here, right? Moan, stones, and groans, Jennifer says. That's great. Great, great, great. So we're taking the calcium, because where else is the calcium from? We're going to take the calcium from our bones and break it down and just hold on to it. So then the calcium in our blood is going to circulate to our organs. And so then excess calcium in our kidneys looks like kidney stones. Excess calcium to our heart. You're going to have cardiac conditions. Excess calcium to your muscles. You're going to have muscle weakness. But you could have excitable deep tendon reflexes when stimulated. Right? So good job. All right, Addison's disease. What hormone is involved with Addison's disease? Adrenal hormone. So what are some of our adrenal hormones? Cortisol. Great. So what does cortisol do for our body? a lot. So adrenal hormones, I think of as your, you have your androgens on one side, but then you have your like epinephrine and your stimulants, right? So cortisol is another stimulant, but it's not thyroid. So this is coming from, where's the adrenal gland? Yeah, so the fight or flight is what I'm getting at. Thank you. I couldn't think of that. So I was like skirting around it. This is where your fight or flight hormones come from. Your autonomic nervous system is going to be reliant on these hormones. So it's a gland that sits on the top of your kidneys. Great job. And so then what does that look like if we have an increase? So Addison's is a decrease. Sorry, I said increase. Addison's is a decrease in that cortisol hormone. So then what does low cortisol levels look like? So again, a stimulant. So low stimulation. Wait, am I thinking backwards? Adrenal insufficiency. You're going to replace cortisol. No. So this is a low cortisol deficiency. That's okay. So then we're going to have Addison's disease is like this pictograph, I guess you would call this. So this is a very dark tan old lady because she feels old. Her entire body feels old. She's got a dark pigmentation on her skin. She has low glucose levels, weight loss, GI disturbances. She can't maintain a activities. And so then an excess in, what was the word I used earlier? An exaggeration of a low cortisol hormone is then going to be this adrenal crisis. So these are your late signs. This is when you really have a problem. So your sodium level is going to drop. They're going to have signs of dehydration. Their blood pressure is going to drop. And their their kidneys are going to shut down. So what does that look like if their kidneys are shutting down? Kidney failure, oliguria. So they're going to decrease their urine output. They're going to have similarity symptoms of, chronic kidney disease. It is not a chronic kidney disease, but they will have a similar symptom onset or presentation. So when you're having postural hypotension, you're going to progress to hypotension. So the exaggeration, that's the term I used before. So then an exaggeration of hypoglycemia, an exaggeration of weakness, okay. Yep, syncope, things like that. So they may not need dialysis. Someone suggested that because we could hopefully re-stimulate the kidney to go back to function by replacing the hormone, right? So then we can replace the hormone with cortisol. So you can have cortisol injections, cortisol medications. Yeah, so if you catch it in time and decrease as much kidney damage as possible, then hopefully this would be reversible and not lead to kidney failure. I am not actually sure of the reason for the bronze pigmentation. Are you aware of the reason, patho, behind that, Miss Love? Melanocyte, something more melanin? I'm not sure. You have piqued my interest. I will have to research it later. So, opposite of Addison's disease being a low cortisol level, what is a high? Because someone already got it. Cushing's is a high cortisol level, right? So then what does cortisol in exaggeration look like? Yeah, moon face. So this big, tall, pale guy, opposite of this old, dark lady, right? So we have obesity, they have a buffalo hump, osteoporosis, moon face, amenorrhea. So what did she, Google, what did she say? So back to the why there's a hyperpigmentation. It is by the stimulant effect of excess adrenal corticotropic hormone, ACTH, on the melanocytes to produce melanin. The hyperpigmentation is caused by high levels of circulating ACTH that binds to the melanocortin in one receptor on the surface of dermal melanocytes, according to a Google research. So, Cushing's being excess cortisol hormone. We have the abdominal striae. You see the little wrinkles and stretch marks on his belly because he grew and stretched very fast, right? Obesity, buffalo hump, some of these already said. Purpura. So what does purpura mean? What do those look like? What are purpura? Little purple dots. Yeah, so they're the red, purple papules, like big petechiae. That's a good description, right? So what causes the purpura? What is purpura? Burst vessels, yeah. So burst superficial blood vessels on the extremities usually. And then they also can have skin ulcers. So then you need to be mindful of infection, wound changes, things like that. Why didn't I put a treatment here? So also what can happen, Cushing syndrome could be as a result of medication regimen. So if someone is on long-term steroid use, like cortisol steroids, cortisol being the hormone that's being used by the adrenal gland, if it's not reuptaked correctly, there's an issue with, I got distracted. then it could lead to Cushing syndrome. In that case, the hope is that we could stop the cortisol treatment and therefore hopefully reverse these symptoms. Well, not reverse, but stop the progression of Cushing syndrome to getting to this extreme extent. But to my knowledge, what's done is done to the body, and therefore it may not be something that can be reversed, if I'm thinking correctly. Right. So diabetes. What hormone is involved with diabetes? Insulin. Where does insulin come from? What organ? Or affects what organ? The pancreas. Right. So what does diabetes look like? Signs and symptoms. What can it cause? Lead to, increased risk for. Right. So the hyperglycemia, the glucose levels are going to affect, again, practically every system in your body. So glucose being your fuel for your body, what effect does that have on your different systems? So you have your retinopathy, you have your organ damage, you have decreased wound healing, increased risk for infection, heart disease, hypertension, kidney failure, right? You have a lot of problems that's going on here. So then there's a lot of education that needs to be given to these patients. So diabetes diagnosed in the pediatric population is quite common lately. So then a client may have to learn how to self-administer insulin injections. If that person is an adolescent, education to that adolescent versus education to the parent of a 4-year-old. How are you going to approach and at their developmental level, explaining how to administer an insulin injection and meet them at their developmental level? So you have to be mindful of those things. So meeting their developmental needs. Needles are scary. They're having to, right. So then on the 4-year-old, you could do it on their doll. A teenager, you could simulate. Yeah, I think that's what you're trying to say. You could simulate it so they can see it, they can practice it, they could do it before they do it to themselves. They could do it themselves the first time, that independence, and that they're doing it to themselves. They don't have to be as scared as someone else trying to stab them. Can help with some of their anxiety. But also you need to open communication with them, right? So you need to know what is most worrisome to that teenager about this process, this procedure. If they don't like the needles, do it to the side of their thigh or the back of their arm so that they don't see it, or that when they're doing it to themselves, the angle that they do it, they don't have to see the needle. You have to be creative. Whereas if it's not the needle, it's the pain, let them try to do it themselves, show them the small size of the needle, do it to the pillow, how it doesn't really affect the pillow. It's not really going to affect you. You can meet them developmentally, right? So then diabetes management. So how are we going to manage a pediatric client with diabetes? What kind of education and concerns are we going to have? Diet. So what's their diet going to look like? Low sugar, low carb. Okay, great. So kids love candy, right? So we talked about in some of the GI stuff about diet management can be very particularly hard for a child whose friends, they haven't learned the habits, they haven't become versed in this diet, and all of their friends are eating junk food or peanut butter jelly sandwiches. And you may not think that but for a hyperglycemic child, peanut butter jelly sandwich can be not good for them, right? So you have to think of carbs, not just candy and sugar too. But it's everywhere, right? Junk food, snack foods, Twinkies, donuts, kids' favorite foods. So managing their diet is going to be the biggest thing. And education to the parent is going to be very, oh yes, juice. Juice is high in sugar as well. All the good stuff. But education to the parents is going to be just as important, if not more important, because they're providing for the child. So they're providing that diet, but also there is some misunderstanding or miseducation, frequently that, oh, I can do that as long as I give myself more insulin or give my child more insulin. It's a balancing act. They can do this as long as I give them this. But as we see for hyperglycemic, that repetitive hyperglycemic spike that is then controlled later by the insulin that you give them damages arteries, veins, kidneys, heart, cardiac, so is it really worth the risk to, oh, they can eat whatever they want as long as I have enough insulin? The education there is that it's not really a balancing act. You need to be proactive, not reactive. Okay. So proactive in exercise, in diet, things like that, instead of reactive and just letting them do whatever they want, as long as I'm still giving them the medicine, I'm still doing what I'm supposed to do, or I'm still taking care of my child, but are you really doing what's the best for your child is the concern. Okay. So then kids, school-age children, they're very active, wild, imaginative, crazy, jungle gym play, right? Last week, Lily was literally climbing all over me during the time that I was lecturing. Thankfully, she was able to go back to school yesterday. So I don't have her climbing on me and while I'm trying to sit here and lecture to you guys. But my point is that age group, they're very rigorous and nonstop, right? I don't have the energy that she has. But that energy being used up in a diabetic client, yes, can lead to hypoglycemia. So before they go do an activity, again, proactive instead of reactive. Before you go to the park, you go and play soccer, you go to soccer practice, they need to make sure that they have that snack so that they can burn through the carbs and not through their serum glucose, right? Always have snacks on hand. So that's a very key part of education there as well, but under the same concept of proactive is better than being reactive, right? Trying to simplify everything down. So then also education, the last thing here is education for mixing insulin. So how do we mix insulin? Hopefully, pediatric clients don't need a lot of insulin, but if you get to the point that, especially if continuous reactive management, diabetes could potentially worsen and therefore need multiple measures of treatment. So if you are needing, in that situation, to mix insulins, mixing being a clear and a cloudy, yes, so then you would pull up the clear first. But think of the whole scenario. So I have a syringe. I have my clear insulin. What kind of insulin is this? Regular. Okay, so then what's my cloudy insulin? NPH, right? So then that was my next question. Thank you, Wood. So then the clear is your fast acting. So then your rapid acting. The NPH, the cloudy, is going to be your slow acting or slower than your rapid. So then, yes, so then you have your syringe, you have your 2 vials. So then you're going to pull the air up into your syringe first, right? And then you're going to put the air of the amount for your NPH into your NPH vial. So if you have 4 regular that you need and 2 NPH, you're going to draw up 6 of air, right? And you're going to put 2 in your NPH vial. And then you're going to draw up 2 of NPH. You have to inject the air first, right? And then you draw. So then what's my next step? Now that I've done the NPH, yep, so with your needle inverted, so up, so that when you push your 4 into your regular, and then you're going to draw your 4. And then you're going to equal 6 mixed in your vial, in your syringe, right? You're confused. What step did I miss? Yeah, clear before cloudy. Oh, look at me. I said it, but then I didn't do it. I even put it in the order too. So you don't. Okay. So my concern, I would do it this way. This is what most recent textbooks are going to say: is finish your regular, and then go to your NPH, because if you inject your 4 into your regular and then you inject your 2 into your NPH, on the tip of your needle, you're going to have some NPH and then go into your regular vial, potentially mixing that. And if that is done routinely or repetitively, as in the cases of hospital multi-use vials, you're contaminating and mixing this regular vial with minute amounts, but when you do it enough, you're messing with your regular vial. So in the terms of multi-use vials, you'll see this in practice. Also, in practice, you will, as Haley mentioned in her clinical rotations, that they don't inject air. The evidence-based practice is to inject the air due to the vacuum that could entail. However, realistically, yes, I mean, you've seen insulin syringes. They are very tiny, very minute. And in most cases, we inject more air than we actually pull out, or very close to it. And so that minute difference, even on multiple occasions, may not lead to a vacuum concern explosion of the vial, but it can. And that is the potential there. And so evidence-based practice is to inject air. And by inserting the air first, you create that vacuum and it is easier to draw up into your syringe, as Wood states. And we've seen that in lab. I had some of you with a 10 cc syringe try to pull without putting air in first. So of course, the larger amount of air, the larger vacuum that it is produced. So again, with an insulin syringe, it is a small amount of vacuum, but it is evidence-based practice. Right. So make sure you understand mixing insulin and how your first step would be air, evidence-based. And then your clear, which is your regular, and then your cloudy. And then you should end up with a total that your added up order was for. So with diabetes being ineffective insulin production, and we're then treating it with a synthetic version of the insulin hormone. And that's where we get our insulin medications. So you will be tested on evidence-based practice, which is what is listed here. And NCLEX will also be evidence-based practice that you would always invert and inject air into the vial first with any medication, not just insulin. So diabetes being these would be the steps here. I'm not sure what you're asking. I will have to review it and get back to you guys. It's not saying air first.
Miss Gilbert?
Mhm.
Yes, it does say air first, but it says what our books want us to do is we inject the air into the cloudy vial first, and then we inject the air into the clear, and we draw up the clear, and then we go back and draw up the cloudy.
And that would be appropriate because you're not mixing your NPH to your regular. Whereas the
Right.
person was, or at least I interpret it as injecting into the regular, then the NPH, then going back to the regular. But you never want to mix what's on your NPH tip into your regular. So that would be fine as well under using the same evidence research.
Okay, because the way you wrote it down here,
Mm-hmm.
it's just different than that. So I was just checking.
So that would be appropriate as well. The concern is mixing these, so you wouldn't do it the vice versa way. But I don't want to stick a vial more than I have to, so this would still be appropriate. So diabetes being not appropriate insulin, so a low insulin level and therefore a high glucose level, because that is what insulin does. This can, of course, you then lead into your types, your type 1, your type 2, but then you have pediatric diabetes, and so then you have maternal diabetes. Then what is the difference between gestational diabetes and pre-gestational diabetes? So knowing the difference in these terms is going to be key to understanding the concept. So pre-gestational diabetes is someone who has diabetes then becomes pregnant. Yeah, so pre-gestation, so pre-pregnancy diabetic. Right, break it down. And then gestational diabetes is that they got pregnant and now they have a diabetes condition. That does not mean necessarily that they are lifelong then diabetic, but they will most likely develop diabetes in the next 20 years. So gestational diabetes is that you didn't have an issue with insulin prior to being pregnant, but now being pregnant, you have low insulin use, reuptake, however you want, whatever is causing the condition. Therefore, having a low insulin, you then have an increase in glucose. So then you have, excuse me, as you see here, high blood glucose level in the mother, which brings the extra glucose to the baby. So then what does that extra glucose being transferred to the baby going to affect? Size. Yeah. So they're going to be big babies or small babies? Big baby, yeah. So then, so they're going to be put on extra weight. What about their skin? What could their skin look like if they're a large for gestational age baby? Yeah, so it'd be similar to a post-term baby. So these babies are large. Yeah. So relate it to what you know. Great. So dry, their skin is breaking down. They look like they're peeling, like a peeling like skin. So what is this gonna, so if they're large for gestational age, what is large for LGA babies inherently increase their risk for? What kind of complications? They'll likely need a C-section, right? Yeah, the fetus might have concerns with hypoglycemia after they're born because they're used to and developed in an environment of high glucose. So they're used to burning off that glucose, right? But then they're born and they can't regulate their glucose. So they eat it up very quickly, and therefore they will actually have signs, symptoms, and serum osmolality of hypoglycemia and trouble regulating their glucose after birth, right? Also, they're going to be at higher risk for respiratory distress once they're born as well, large for gestational age, right? So back to the mom. What kind of education and concerns are we going to make sure that the mom is aware of? Besides that, the education to the parent, to the baby. What specifically can the mother do? Diet, exercise, right? Just like before. Now, they actually have a specific recommendation for maternal, so gestational diabetes. They want to limit their carbs to calorie percentage intake by 50%. So this means 50% of your calories need to be carbs, no more. Most people, and especially in America's diet today and age, carbs are probably more like 60, 70, 80% of the diet. So this is actually cutting back their carbs, but not to a no carb, low carb diet. They still need some carbs so that they can utilize that glucose and breakdown because they need some sort of energy, right? But for it's a little balance there. So half of their calorie intake needs to be carbs. Now, no, so whatever their calorie intake is, so if their calorie intake is 2,000, I think is what it was, then 1,000 of their calories needs to be carbs, and only 1,000. No more than that. Yeah. So how do we normally treat diabetes though? What kind of medications besides insulin? Oral hypoglycemics, like what? Metformin. Metformin is very common even in pediatric population. However, it's not really recommended during pregnancy. So this is your special medication for gestational diabetes, glyburide. It's considered safe during pregnancy. So the gestational diabetic mother may need to be transitioned to glyburide if she is on metformin or multiple or glycemic dependent diabetic. But this medication has little crossing over to the placenta and would be therefore in the same respect safer than other ones for breastfeeding as well. So glyburide is different than glyburide. So this is a different medication. I've actually never seen this one in real life. And then I think I've already mentioned this, but just to reiterate, so their incidence of gestational diabetes means that once the pregnancy is over, they will likely return back to normal insulin hormones and therefore being able to control their glucose again. However, it predisposes them to develop type 2 diabetes later. And so in about 20 years, they are likely to become a diabetic. Right. All right. So all of your endocrine information came from your textbooks from these pages. Do any of you have any questions about the endocrine topics? Concerns, question maybe that was in the chat that I did not see before we wrap it up? Yes, Wood. Okay, great. So this here, she says the ATI video case study mixing insulins. Is that what you're saying? The step-by-step video or a skills module? Okay, so there's a skills modules for insulin as a resource. I will edit and put that in here as well then. Thank you. On how to mix insulins. I am also sleepy. Okay, guys, thank you all so much. We are going to be continuing to review the exam and let you know as soon as possible and post those in the gradebook here in Canvas. As I stated in the announcement earlier, that there are a few students that need to take the exam on Friday. Therefore, the topics to review will still be hidden until then, but you will know your grades. And remember your exam remediation. If you are, if your attempt was a less than an 80%, you're recommended. But if you're less than a 70%, you are required to perform the exam 3 remediation. Once we get done reviewing the exam, we'll create those questions here. It's a little Quizlet of questions similar to the ones posted in the exam or presented in the exam will be posted here to help with rationales, okay? And then you will also have to meet with an instructor as well as the part of the requirement. So we will let you know when all that is finished, when this is available, but you can go ahead and start on your review for your endocrine items and your Venn diagrams for your learning assignment that is due on November 30th. For a 70 or below, yes. So a 70 or below, you are required to meet with an instructor as well as perform that quiz. A 70 to below an 80, you are only recommended. Everyone else, you are welcome to, but not required. All right, guys, thank you so much. I'm gonna stop recording. Y'all have a great afternoon.